As because of more prominent nature, mandible may subject to frequent fracture than any other facial bones. Horseshoe-shaped mandible is most rigid and mobile component which forms the lower third of facial skeleton. It forms a joint with glenoid fossa of temporal bone through head of condyle. The joint has upper and lower compartment and this fibrous extension runs in between and articulates the fossa and condyle. Now let's see about the anatomical areas of weakness considering tooth as most important factor for fracture occurrence. Upon extraction, canine with long root, unerupted tooth especially premolars, part erupt wisdom tooth represents line of relative weakness. The slender morphology of neck of condyle may get easily fractured. Fracture at angle of mandible is influenced by medial pterygoid, masseter sling and are classified as horizontally favorable where fracture line extends from upper border downwards and forwards, but displacement of fractured segment is prevented by physical obstruction of mandibular body. In horizontally unfavorable fracture, the line extends from upper border downwards and backwards where fracture segment follows the unopposed action of masseter and medial pterygoid in an upward direction. Another end classification as vertically favorable where fracture line runs from outer buccal plate obliquely backward and lingually restricts the medial movement of fractured segment. In vertically unfavorable, fracture line runs from inner lingual plate obliquely backward and buccally resulting in unrestricted pull of fractured segments lingually by medial pterygoid muscle. Primary care should be given for bilateral parasymphyseal fracture. Leads to bodily backward displacement of tongue and its attachments, results in closure of both oro and nasopharynx, and it can be managed by bringing forward with finger placed over posterior third, and fractured segment should be aligned and temporarily immobilized. Let's get into few important clinical features and their management. By dentoalveolar fracture, there happens mobility of that segment, subluxation or avulsion of tooth, vertical or horizontal split of tooth, which can be managed by intermaxillary fixation starting with reduction of fractured segment and placing the jaw in centric occlusion, stabilizing with direct wiring if patient have satisfactory complement of teeth in both the jaws. For better grip, clove hitch type of wiring can be done around the tooth. But only disadvantage is for releasing individually wired tooth, all the wire fixation must be removed. But interdental wiring overcomes this demerit by adapting the wire in the cervical region for better stability by placing 5 eyelids in both upper and lower jaws starting first at molars and then to the anterior region. Finally, intermaxillary fixation is achieved by connecting the eyelids by wires and tightening it. This method can be utilized for condylar fracture too. For fractures in the edentulous mandible, gunning type splints are used which are retained using circummandibular or peralveolar wiring. Fracture of ramus or angle is managed by transosseous wiring either in the lower or upper border whichsoever get involved in the fracture. Body fracture utilizes compression plates which are placed near the lower border results in open up of fracture at alveolar margin and hence a tension band should be applied previously to avoid distorting effect or else the same effect can be achieved by prior application of small non-compression plate above the level of inferior alveolar canal. Thanks for watching. Hope you will like my video. Please share, subscribe and comment.